This presentation is for the subject Sports and Exercise Psychology for the University of New England for Dominic McNeil, lecturer. My name is Neil Dunning. The oral presentation and topic is Anxiety Depression in the Setting of a Cardiac Rehabilitation. It has been reported that there is a commonality of depression and those that have coronary heart disease. Following an acute event, most likely a heart attack, shows that between 17 and 27% of episodes of major depression within the months soon after the acute event of a heart attack. However, not all end up with major depression, and only some symptoms may reveal themselves in the experience of many other people. Symptoms and occurrence of depression can even be delayed up to 12 months. In the fight against depression, physical activity has been shown to be as effective as antidepressants in mild or moderate depression. The issue, however, is getting people to engage in sufficient level of physical activity to reach positive effects. The other issue in this battle is that the person's already depressed state may get in the way of adherence to physical activity if there is a diagnosis of coronary heart disease or acute coronary syndrome. Everyday stresses can enhance an already susceptible person to advance in the manner that places a further burden on the cardiovascular system. Such lifestyle behaviours are lack of exercise, lack of pleasant activities, inadequate diet and sleep, hostile behaviours, smoking, excessive drinking and social withdrawal. Depression and anxiety may often be seen more readily by persons, spouses, partners, another family member or friend that have regular contact with the patient. Even though textbooks and articles look at depression and anxiety starting at a later in the timeline of a cardiac event, that is prior to, during or even after cardiac rehabilitation, in reality it should be seen as though there is a possibility that it has started at the time of entering hospital, and in the case of anxiety, pre-hospital, with the onset of symptoms of a possible heart attack. In the case of depression and anxiety, this may occur on entering the hospital. It would come with the reality of when the medical or nursing staff would inform the person that their family that the results they have been taken have come back positive for a heart attack. Cognitive and behavioural change may alter a person who is yet to get to the stage of severe depression, where there would be a need for greater interventions such as psychiatric or psychological counselling and the possibility of use of medications. However, if this was looked at as a preventative intervention for both depression and anxiety, cardiac services from within the hospital or community should be considered. Using early intervention from the cardiac rehabilitation staff, initially being the registered nurse explaining their role and the role of the hospital cardiac services. This attempts to put their mind at ease that they won't be just put out of the hospital on their own with their family to cope. Overcoming depression and anxiety starts with staff on the ward the person is on, getting the patient up and mobilising as soon as possible. This is encouraging positive activities that initially lessen the possibility of depression and anxiety. This then can be extended to walking further distances up and down the corridor of the ward whilst under the observant eye of nursing staff. Visits from the family and friends at this time may also aid in the hospital, and going for short walks initially within the ward with them. This gives comfort in knowing the medical nursing care is close and decreases their anxiety, but also that they don't necessarily have to play the sick role and be closed off to the world. They see that they are not isolated, which could lead them falling into further depressed state. Extending these walks even further still in the confines of the hospital, as the discharge time comes closer, walks could be taken with family and friends outside hospital walls or to the hospital cafe. Again, knowing that they are not far from medical and nursing help, in most, if not all cases, being centrally monitored through the use of telemetry. This gradual scheduling within the confines of what could be seen as a safe environment, and the person doing this is there is a sense of accomplishment being given. In effect, self-efficacy being commenced prior to discharge. In this process, the idea of anxiety could be negated or at least minimalised at the start of aiding in preventing depression. A small qualitative study of only 15 participants showed reasons or barriers that people could face that the depressive symptoms may use in using physical activity with the diagnosis of coronary heart disease. It only gives a snapshot with these 15, and not. However, it would be something that can be built on not necessarily by researchers specifically, but facilities that provide such services. This could be used in the interview process and beginning of a person's rehab. Some reasons used by participants are not unlike those of us in the general population who weren't ill. Comments were made such as, "It's not the physical side that stopped me from getting up and walking around the block, it's more the mental side of things." Another comment referring to low mood was, "When I'm feeling down, I can hardly even get myself out of bed, let alone do the exercise." This is why there should be needs to be encouragement began at admission of a person with a cardiac event. It may be hard for staffing levels on the wards, but multidisciplinary care aids this situation. Visits from physios with a basic exercise program that can be monitored. The monitoring of this program and encouragement from both ward staff and doctors would all be contributing factors in aiding a person to get through or lessen depressive symptoms. Their own health was a barrier to physical activity, with comments like "on a downward slide" and "harder to exercise when you thought like this." Others talked of shock as they thought they were bulletproof. It slowed them down. Before their heart attack, they felt fit. Now they perceive themselves as older and slower. Physical restrictions were pointed out by participants, stating not having the same stamina or reserves in the body. Other physicals got in the way as well, were injuries, for example, lower limbs. However, at this point, it can be pointed out that exercise could be altered for them to continue and not stop the good work that they have started. Fear of exercise and the worry of harm of exercise might to them, causing further damage to their heart and their aging body, seen as an impedance to the recovery. These were negatives that were pointed out by participants of physical activity and depressive symptoms. However, once participating in physical activities of cardiac rehab, the following positives was seen and mentioned by the small group of participants. The following statements from the study: like therapy for your mind and body, mental attitude change for the better, makes you feel good within yourself and gives you a mental uplift. Anxiety and depressive symptoms could be removed when removing social isolation. Seeing others in the rehabilitation group who started from where they are and what they are now achieving through rehabilitation. People may share similar stories of life with them. Once again, not unlike the wards in the early stages of diagnosis, the staff were checking on them and asking how they were feeling and checking levels. This would be seen things like heart rate, oxygen saturation, and pain in the difficulty scale, a Borg scale, known as a Borg scale. Going through this process could be pointed out in a behavioural mode known as trans-theoretical model, which is 5 phases, including pre-contemplation, a person not even thought of becoming physical activity or may be unaware of the importance. This may be seen within anxiety and depression. Contemplation may be thinking of change to be active in a short-term future, tipping point not reached to change behaviour. Depressive symptoms and anxiety could interfere at this point. This may all be happening while still in hospital. Preparation. The tipping point reached as a person is discharged from hospital and referrals are in the hands of cardiac rehabilitation services. Psychological strategies here would include goal setting, eliminating excuses. Action. Either physical activity as opposed to previous sedentary life or trying to recapture some of the previous physical activity that was enjoyed by the patient. Going to cardiac rehabilitation program. Psychological strategies here would be meeting goals. Positive self-talk will be used at this phase, even commencement of a diary writing that could start here after each rehab session. So this could be continued in the final phase. This may also be used as a pedometer in the number of steps or how far they travel. Maintenance. This is when a person has been in physical active for 6 months. Psychological strategies here would be extending and setting new goals, continue positive talk, continue to eliminate excuses, and making priority of exercise by continuing to writing the diary. Stress processes sought out at this time. Stage 1, environmental demands. Will I leave, alter work? Will it happen again? Will I be able to contribute to my family? Will it change me sexually? Will I become socially isolated? Stage 3, stress response, anxiety. Headache, am I having a stroke? Short of breath, chest pain, sweating. Is there another heart attack? These symptoms may not happen altogether. Stage 4, behavioural consequences. Anxiety of leaving the house. Anxiety of having holidays away from medical care. Medical model. Continuous trips to hospital, use of ambulance, poor intake of education, thereby limiting self-management. Reversion back to depression. Feeling of not being able to contribute. Loss of control of life. Dictated by doctor's visits and medication. Some reliance on others. Thank you.